Thank you, and I think it will be a big challenge for me to continue after such prominent urologists. But before we will turn to MR-guided biopsy, let us have a brief glance at data and insights from a urologist's perspective concerning biopsy of the prostate, and I think we completely agree. In 1994, Epstein reported that needle biopsy pathologic finding at PSA are accurate predictors for tumor extent. 2 years later, significant predictors are maximum length of cancer in any core and PSA density. A little bit later, carcinomas are multifocal, as we have heard in most of the cases, and demonstrate histologic heterogeneity. Tumors are multifocal and bilateral in many cases. However, as already mentioned by the presentation by Javan, in recent years there are also reports like that from Hamden. Biopsy findings are not representative and small volume cancer are not necessarily insignificant. So I think we agree there is room for improvement. And this improvement may be obtained by MR-guided biopsy. However, I was asked to talk about the pros and cons of this technique. MR-guided biopsy is an established procedure, initially reported by D'Amico in 2000 using the transperitoneal route at Lowfield. In 2005, Dirk Beiersdorf from our department published his patented procedure by the transrectal route at Highfield, and currently this is the most frequently used technique for MR-guided biopsy. Usually, we need an in-room time of 30 to 40 minutes, and we obtain 2 up to 3 biopsies per suspicious lesion. And in general, there is little to add concerning technical aspects. Recently, Tahir Durmuş published his data that 16-gauge and 18-gauge biopsy needles yield similar diagnostic specimen quality. However, most institutions prefer the stiffer 16-gauge needle, and we recommend to use 16-gauge needle if the lesion is deep inside the prostate, for example, in the ventral part. And Van de Ven also made the statement, if you want to get the high Gleason grade component in nearly all of the peripheral zone tumors, a technical registration accuracy of about 2 millimeters is required. And to improve the technical registration accuracy, there are several robotic-guided systems under evaluation. Let us have a look to one case. This is a 70-year-old patient with a PSA of 10.8 and 4 negative previous TROS-guided biopsy. Difficult to see on T2, clearly identified on the diffusion-weighted image, and MR-guided biopsy have been obtained of this lesion. Finally, it was a Gleason 4+3, a significant prostate cancer. And I think that previous TROS-negative patients with an elevated PSA are the most prominent candidates for MR-guided biopsy. And at this place, I would like to refer to the very big, including several thousand patients, which was published by Bob Javan and co-workers, the European Prostate Cancer Detection Study. And as you already mentioned, the percentage of detected cancer is decreasing with increasing sessions of TROS-guided biopsy. Tahir Durmuş performed another study where MR-guided biopsy was performed as the second set of biopsy, the third set of biopsy, or the fourth and beyond set of biopsy, and still the detection rate is high. This means that the detection rate of MR-guided biopsy does not decrease with the number of previous TROS-guided biopsy. So there are difficult regions in the prostate to be reached by TROS-guided biopsy, and these are the ventral parts of the prostate, the apex, and the very far lateral part of the peripheral zone. And if you allow, I would say that systematic TROS-guided biopsy may have a systematic error. Of course, there are strategies, as we have just heard, to improve TROS-guided biopsy. Of course, you set the troops, increase the troops, obtain more biopsy cores, increase the biopsy cutting length, depth, and number of cores. However, there are also reports which are mentioning that an increased risk of infectious complications exists with every additional set of biopsy. Therefore, now let's have a closer look to MR-guided biopsies. There is an increasing number of publications. And if we try to get the summary of these publications, then we can make the following statements who are in favor of MR-guided biopsies. MR-guided biopsy is more efficient than systematic truth biopsy. The detection rate of truth-negative patients is roughly in between 40 and 50%. MR-guided biopsy yields longer core cancer lengths than truth-guided biopsy. Another very important statement, MR-guided biopsy detects more significant and less insignificant cancer. Usually, we need to have only fewer cores per patient, and MR-guided biopsy performs better than cognitive biopsy. Sounds good. However, Bob Jaban was very critical with urologists, and now I try to be a little bit critical with radiologists performing MR-guided biopsy. I think we should be aware about these facts. Most studies are retrospective analysis. There are only few prospective studies. Most are single-center studies, including biopsy-naive patients, post-biopsy patients, patients with known cancer. Usually we have small number of cases in the studies, different techniques of image-guided biopsy, and these different techniques of image-guided biopsies are not compared in one and the same patients. So let's go to the literature again. Most studies include very little number of patients, with a few exceptions. And some studies are mixing up biopsy-naive with truth-negative patients, and therefore these are the cons concerning MR-guided biopsy. It's a time-consuming procedure, it is relatively expensive, and above all, we have limited data and therefore little or no evidence. And just make it clear, MR-guided biopsy studies include patients in the range of 10 to 100 and usually single-center studies, whereas we have just heard truth-guided prospective studies include a lot of patients and usually are prospective multi-center trials. And an international working group made the statement that there is poor adherence of studies to standards in reporting diagnostic accuracy, and in addition, believe it or not, we do have false negative findings. So this brings me to the question, how good are we? So this is a 49-year-old patient with a PSA of 9.5 and 2 negative previous truth-guided biopsy. So we rated this signal loss as a PIRATES 2, maybe chronic prostatitis, and identified this lesion at the apex of the prostate as the dominant intraprostatic lesion. We performed an MR-guided biopsy. However, it was no cancer. 2 years later, still increasing PSA, additional MR examination, the signal loss vanished in this area, and the lesion at the apex of the prostate becomes bigger. Finally, this was prostate cancer. And Walton Diaz recently published that cancer detection rates decrease with increasing prostate volume. This is not a big surprise. And so we have to deal with false negative results mainly in small lesions, big prostates, and in addition due to displacement. We already think that the prostate is a strong organ with no displacement, but look at this case, pre-biopsy MR, and during the biopsy, this significant displacement of the organ, which may also yield false negative findings. And Caroline Herx reported in her publication 9 patients out of 117 patients finally had false negative MR-guided biopsy. Usually we believe in images, so we believe if we see the image, if we have the needle, we got it, but sometimes we have false negative findings. So what do we need? Of course, we need a modality which is highly sensitive in detecting the significant lesion, which should be anatomically precise. In addition, it should be fast and real-time, it should be affordable, and also may have the option to perform an additional set of systematic biopsies of the prostate, and this can be obtained by MR ultrasound fusion biopsy. So like in this case, patient with an elevated PSA Do you see any suspicious lesion, even in high-resolution ultrasound? Not really possible, which is much easier done on multiparametric MRI. Suspicious lesion in the ventral part of the transitional zone, not detectable on ultrasound elastography. However, with the knowledge of MR, you may see a hypervascularized area on contrast-enhanced ultrasound. So in combining the MR with ultrasound, it's easy to detect and biopsy this lesion under ultrasound guidance. And finally, this was a small Gleason 4+3 prostate cancer. The next one is an example of a sensor-based MR ultrasound fusion biopsy in a significantly enlarged prostate. The suspicious lesion was marked on ultrasound. The needle was propagated with distortion of the prostate to avoid there was a restriction of the needle, and then the needle was fired. So there is an improvement. And we are talking about different techniques in prostate biopsy. So let me try to compare these different techniques of prostate biopsy. And we didn't arrange our talks, and you may see similar images now. So we have the blinded random biopsy. We do have the cognitive biopsy. We have the single tool biopsy, like the MR-guided biopsy, and we have the double tool, the MR ultrasound fusion biopsy. So please make your own decision. I know this is very subjective, so let's go back to the literature. This is the MR-guided biopsy literature. This is the MR ultrasound fusion biopsy. And most studies, recent studies, are dealing with MR-guided ultrasound fusion biopsy. And above all, in the meantime, there are much more patients included in MR ultrasound fusion biopsy than into MR-guided biopsy. And our own data in our institution reflect this observation. During the last years, we have a relatively stable number of MR-guided biopsy, which is not paid by the insurance companies. But since the introduction of MR ultrasound fusion biopsy in our institution, the targeted biopsies are significantly increasing in cooperation with the urologist. And this brings me to our conclusions. First, let's have a look to the pros of MR-guided biopsy. Multiparametric MRI enables detection of significant cancer and can be used to guide biopsy. MR-guided biopsy is an accepted tool, especially in patients after choice negative biopsy. MR-guided biopsy has high cancer detection rates independent from number of previous choice-guided biopsy. And now, let's have a closer look to the cons of this procedure. We should be aware of false negative MR-guided biopsy results. There's little evidence due to limited data. MR-guided biopsy should only be used in selected patients. And there's a trend in the literature as well as in daily practice from MR-guided in-bore biopsy to MR ultrasound fusion biopsy, and I think this will be a perfect introduction to the next presentation from François Cornu. However, as a radiology community, we should be aware that there is a need for robust multi-center clinical trials of targeted biopsies of the prostate. With this, I would like to thank you, and I'm available for questions.